Hi, good morning, everyone. We are live on yet again, a new session. Today, we have a very important topic. We're talking about advancements on GI and HPB. But before we move to that topic, we have Dr. Heidi and Dr. Monica. Dr. Monica, would you like to ask that question? And then
Oh,
we'll take the session.
yes. Thank you, Saurabh. And we have a very special guest today. Every guest is special, but Dr. Heidi Stensmeieren was the former president of the World Medical Association and had been part of our forum and shared a lot of international perspective. And her presence is very welcome today. The question I had is that, we convened this group to bring together ideas, people, thoughts about how to take care of our communities in an international forum, sharing ideas. And the question I have for Dr. Stensmeieren is, what does she see, or what do you see as being the biggest threat to providing healthcare in the global stage today?
Mm, thank you. Thank you, Monica. I'm very happy to be here. I can tell you I'm continuously following your work, and it's an admiring work. And um, so the question is a huge question, Monica. I guess you know. But we have several threats. I mentioned briefly earlier, and I will recall that one, how healthcare is used in conflicts many times. We used to operate to help everyone. Now, healthcare workers are more targets when we have conflicts, and we have multiple conflicts. That's not the biggest part of healthcare, though, healthcare and conflicts. So when we look at healthcare in the bigger picture, I would say the challenge with access to healthcare and the pressure it puts on healthcare workers, that's maybe the biggest challenge. Many healthcare workers witness of a fatigue, of this ethical stress of providing care, but maybe not be able to during high workload, or actually a lack of access to medications, or lack of healthcare for bigger groups in the society. That's a big challenge because even if a country has access to healthcare on paper, it doesn't mean that everyone has access to healthcare. And in the end of the day, it's the doctors and healthcare workers that are handling that every day. So that's a big challenge for healthcare workers. We also see a big challenge in access to education and continuing education during a career. That's coming up. It's a bigger one. But I would say the workforce is under pressure in many places. We are a vital part of society. Every well-working society has a well-working healthcare system, but it is a challenge to provide that care on a day-to-day basis. So I would also point out one more thing. There are more and more medications coming up, and there are advanced treatments, but it is a challenge if we can't provide it. So provide access to care is challenging, let's say. In brief, we can elaborate more about these things. On the other side, it's also a very interesting time for healthcare since we do have more advanced therapies coming to more and more people. So we are able to treat more people today than ever, which is good. And I think the healthcare is now recognized as so important. That's why I think doctors will have a better position in the future. Well,
Thank you.
thank you. Thank you for
Now,
arranging this.
of course, thank you for sharing your views today. I'll pass the floor to Saurabh as he will introduce our new speaker and to talk about our topic of this week and how we can improve our care or understanding other topics. Thank you again, Dr. Stensmeieren, and thank you, Saurabh.
So thank you, guys. And I welcome Dr. Heidi as a speaker on this session in coming up next month, I would say. Uh, And thank you for joining. I think it's 6 a.m. for you guys. Uh, okay, coming to the important topic. Today we are talking about advancements of GI and HPB. It's a very, very important topic in terms of surgery. Uh, uh, Gallbladder, gallstone. So to talk about this, we have Dr. Suddhasattwa Sen. He's a highly accomplished GI and HPB oncosurgeon from Kolkata, a gold medalist, MBBS, MS, and DNB in general surgeon. Dr. Sen holds various and several prestigious qualifications, including MRCS UK, DNB GI HPB surgery, FMAS FICS USA, an advanced fellowship in HPB and liver transplantations from leading institutes like Shri Gangaram Hospital and Apollo Hospital in Delhi. He is a senior consultant in GI, HPB, and oncosurgeon at Technodrama and HPB hospitals and has previously held leadership roles at IRIS, AM, RI, Fortis, and Apollo Hospital. With over 25 years of experience, he is a recognized expert in complex GI surgeries. Sir, over to you.
So thank you, Saurav. Thank you all the august body here, and also welcome to all the dedicates who are going to watch this program. So do I share the screen and start the presentation, Saurav?
Please go ahead.
Yeah, thank you so much. So the topic for today, as we know, is going to be on the advances in GI HPB surgery. And uh, is the screen visible?
Yes, sir.
Yeah.
Thank you.
So basically, what we are going to run through is, since the time isn't very long, so we're going to run you through the different types of GI HPB surgeries that we have come across, the GI HPB cases. Where were we 25 years back in the world, and where have we come from there? Have we really crossed the bridge? So this is the domain that we work in, which starts from the mouth, ends in the anus, and is divided typically into the upper GI, the lower GI, and the hepatobiliary pancreatic system. And just to give you some ideas about where we have come to world record cases, which were previously thought to be inoperable. This is the largest world neck tumor. This is the largest primary gastrointestinal stromal tumor of the pancreas. These surgeries have been done quite many years back. These patients are on follow-up because ultimately there is follow-up. You would not know whether the patients are doing good or not. The patients may have survived initially, but long-term follow-ups is actually what is most important step in a surgical procedure. This is a picture which was taken 25 years back when the cancers of the pancreas were involving the vein and artery. It was considered to be inoperable. And these were one of the first cases in Eastern India where we had actually cut out a part of the vein, also a part of the hepatic arterial trifurcation, and reconstructed them. From there, we have traversed a long distance. Now, veins are being cut routinely. They can be cut and replaced by grafts. The arteries are cut routinely. There are new procedures called the Appleby procedure, where even the celiac axis is cut and reconstructed. Then the SMA has been cut. There is the section in the periadventitial tissue of the SMA to take the tumors out. There are SMA first approaches now coming up in pancreatic cancer surgeries. This was the largest liver tumor ever taken out. This was in an 11-year-old girl. So this was a case of the longest gangrenous gallbladder ever done in the world, done laparoscopic in spite of being 1 feet in length. This is one of a very rare surgery where a non-occlusive mesenteric ischemia at the age of 93 survived, the first survivor in the world who also had a pancreatic cancer. This was a patient who had a severe gallbladder injury at some other place. And then there was injury to the liver, the bile duct. There was 9 liters of bile, pus, and blood in the abdomen. The patient had multi-organ failure, was referred to us on ventilator, dialysis, highest noradrenalines, and stuff like that. He was just 11 years old. And he survived. And today he just came and met me. He's now become a doctor. He was highly influenced by the survival. So he decided to be a doctor instead of engineer. and he is a doctor now doing his post-graduation. So this is how we have evolved and advanced in surgeries. Like initially, the gallbladder cancer surgeries were all open. Now it shifted to laparoscopic surgery. This is a picture of the first laparoscopic gallbladder cancer dissection that we did way back in 2014. Since then, there have been multiple cases. Like we all know, the first case is always the most difficult and challenging. As you go forward, you gain either lessons or memories. You work on your lessons, you introspect, you retrospect, and you get better. And that is what is truly what we mean by advancement in GI-HPP. Where we have shifted is to doing clean surgeries. So nowadays, for the last 14 years, we have focused on bloodless surgery where we lose so less amount of blood. The dissections are so co-planar. We use so much amount of energy sources that the patients lose hardly 10, 20, 50 ml of blood instead of liters. We are not transfusing them. We are not even sending them to the ICU. Even the VPLs, the liver dissections are going to the ward, and then they're being discharged without a complication in the next 5 to 6 days. So we have reduced the average length of stay, we have reduced the blood transfusion rates, we have reduced the blood loss, we have done very clean and adequate dissections without compromising on the oncological principles of safety, yet having the patients alive without complications. So this is a D2 gastrectomy showing what is a bloodless surgery. You can see the arterial branches. This is what is meant by a bloodless surgery in a chronic pancreatitis. You hardly will see blood or blood clots, and we cannot just wash it away. So these are clean surgeries to start with. These are typically where initially piles was being done. You cut it out, and then came the Doppler hemorrhoidal arterial ligation, cryotherapy, infrared therapy. Finally, it became the stapler procedure. So you have large grade 4 piles. Immediate post stapler, you can see the piles are no more visible. It is gone inside. The vascularity of it has been taken away. So we combine it nowadays with laser, with injection therapy. So it's not always just one procedure that would help in piles. And we have done more than 27,000 cases so far, very successfully, with only 7 cases had bleeding. These are typically the liver dissections initially used to be quite crude. Now with Belgati's hanging method and so many other instruments available, CUSA, water jet, the Habib's probe. So the liver dissections has become much more advanced, much easier, much more predictable, and you can actually do it without having liver failures or other complications like bile leaks and bleeding and stuff like that. Initially, 25 years back, the gallbladder cancer redo surgeries where the gallbladder had been taken out, incidental gallbladder CA has been found. We would go in and do the lymphadenectomy and take out a wedge of the liver. So this used to be only a 2 centimeter wedge of the liver. From there, it came to a complete wedge resection of the liver, which was a 3 centimeter segment 4B5. From there, we had progressed to doing laparoscopic radical cholecystectomies. This is just a classic Whipple's, just to give you an idea about what Whipple's removes. This is a classic esophagectomy. This is a laparoscopic esophagectomy. The advances, what had happened in esophagus surgery is previously it should be always open, be through the abdomen or the chest. Now you can do it laparoscopic, VATS, robotics, you can do it combination. These are the typical D2 gastrectomy. Previously, many years back, it was just a stomach excision. Now it is a stomach excision with the entire lymphatic drainage. The entire lesser sac is being taken out. So that is the amount of specimen that you have, so that you can actually make out which ecolone lymph nodes, what are the number of lymph nodes. You can actually prognosticate the disease properly. So the pathological staging happens best. This is just to give a idea about a unique case. This is a hydatid cyst of the pancreatic tail, which is very uncommon. We know it happens in the liver and spleen, in other organs, but in the pancreatic tail is very rare. So I thought it would be nice to share all of you. And this is a multivisceral dissection. I'll not talk about it now. I'll talk about it as we progress in the lecture. And these are retropetal tumors. These are typical colectomies. The upper one is in ulcerative colitis, total proctocolectomy with pouches. And the lower one is panproctocolectomy with, in a case of FAP. Now, what happens, what is the advancement in colorectal is that we are doing almost all surgeries laparoscopic. Some are being done robotic, some are being done hybrid. You can do a total colectomy, a right, left, central colectomy. You can do an ultra-low anterior dissection. You can do an APR laparoscopic, and it has actually made the life easier. And the anastomosis can be done with help of endostaplers, so which is a big advancement in the surgical fields. And then with circular staplers, you can anastomose the left colon rectum side. You can do the same with linear staplers in the laparoscopic procedure. So it's not necessary that you have to cut the abdomen open. So these are the advances in colorectal. But in HPB, again, when we focus, the topic today is HPB. So previously, we believed that difficult gallbladders would undergo open surgery. For the last 27 years, we have not opened a single case. We have done MIRIZI 1, 2, 3, 4, 5. We have done empyemas. We have done perforations. We have done GB phlegmons. We have done as small as 5 millimeter GB, which happens to be the smallest in the world. We have done the longest gangrenous GB in the world, 1 feet long gangrenous. We do gangrene gallbladders, acalculous cholecystitis, gallbladders in cirrhosis livers, gallbladders in portal hypertension, gallbladder in redo abdomen where multiple scars are there. So you can see this amount of adhesions are there, that the guts are all adherent, but still the liver is cirrhotic, but still we would do a gallbladder surgery laparoscopic. So these are really the advances that had happened over the last 25 years. Our skills have improved, the technology has improved, our guidances have improved. And now with AI coming in big time, probably there would be a day when actually AI would complement the surgeons. Now we know that autonomous robots have started. I mean, just 2 days back news, autonomous robot has started doing gallbladders in a simulation. So obviously, it's yet to be seen whether the humans are replaced by the robotics. But at the same time, I think it's pretty far away. Until then, AI we can use to our advantage, where AI, robotics, analytics, predictive health all would add up to the advances in GI/HPB surgery. Just to give an idea for the non-surgeons, who is a gastrosurgeon or a GI oncosurgeon? A surgeon who does GI cancer surgery or as well as non-cancer GI surgery, be it open, conventional surgery, laparoscopic, or by robotic surgery or by hybrid methods. The surgeries that would do are hepatobiliary and pancreatic, esophagogastroduodenal, the small and large bowel surgery, anorectal surgery, hernia peritis, retroperitoneal tumors, and the last but not the least, liver transplantation, which was my subject in the year 2006 when I was the first liver transplant surgeon of Eastern India. So whether you continue in liver transplant or not, what it really makes a difference in the way you look at the surgery, the way you approach a patient, your philosophy changes, your approach to surgery changes, your skill set changes, and the livers become much easier to deal with. And you are no more afraid of the unseen or unexplored zones in the abdomen. Because once you've done liver transplantation, then every other surgery becomes quite easy for you. Now, the cross changes that had happened is open had shifted more to laparoscopic, to came an era of hybrid surgery, which was an open laparoscopic, endo-laparoscopic combination, now shifting more to robotics. We have shifted more to bloodless surgeries and non-transfusional surgeries, autologous transfusions, ICU-less surgeries. We have realized it not only saves cost, it saves the cross-infection, unnecessary investigations, and actually the patients do better. We have been doing this for the last 14 years, and our death rates are almost below 0%. Our complication rates are below 0%. Organ preserving surgeries have big time come up. Like previously, we would resect a lot of things. Like there was all over Google, you can find this news that a young girl had come for a Spain, and the rest of the world had suggested Whipple surgery to be done. We didn't do it. We did an isolated pancreatic uncinate resection, a very, very difficult, challenging surgery. She survived, and she's still surviving, in touch with me for the last 3.5 years on follow-up. So organ preserving surgery is big time coming up in all the HPB surgeries. That's the reason the role of neoadjuvant chemotherapy, the neoadjuvant therapy in case of large cysts with imatinib or sunitinib or something like that are increasing. There was a time when there was all multivisceral involvement or multivascular involvement were considered inoperable. Now it is no more. So then there came a time 20 years back, we were doing multivisceral, multivascular dissections. So take out everything when it comes to cancer to increase the quality of life, if even if not the actual survival or overall survival. And then came a time of organ preservation where more and more role of neoadjuvant therapies were utilized to shrink the tumor, to make the surgeries more of R0, that is the margins negative. And that is something which is going to increase over the years in future. Multivascular, multivisceral dissections, last but not the least, still remains a very important factor when it comes to cancer surgeries. Now, the rest of the presentation is going to be pictorial as I speak along with it. This is a typical incidental gallbladder cancer. This is a large gallbladder cancer. So, where have we really advanced? This is a picture taken 27 years back. So here you can see how crude the method was to resect the liver. You pull it up with sutures and then you cut and you suck and you crush and you cut. So it was a very crude procedure with a lot of bleeding. And this was the result of that liver taken out. And this was the liver bed. But from there we have evolved and adapted to come to laparoscopic liver resections, laparoscopic radical cholecystectomies, even with very late minimal blood loss. Yes, it takes a slightly more time, but then ultimately, since you don't have to open the abdomen, all those don't have to close the abdomen, at least half an hour, 40 minutes saved over there. So it comes to by and large more or less the same thing. This is just a gallbladder, porcelain gallbladder. I want to show you a picture of a gallbladder sarcoma. The treatment remains same. Coming to liver metastasis, so there was a time when people thought liver metastasis is a disseminated disease and nothing would be done. But now we know that in colorectal liver metastasis, you take it out, you operate it, you resect it. And we were proponents of all very aggressive surgeries for a very, very long time, even before it was actually really well accepted in the world. It wasn't a very benchmark practice when we started operating on these things 20, 25 years back. And we are doing more advanced surgeries now. I'm not going into that because some of them may be controversial, debatable, but well within ethical permits because we always get that permissions before we embark on to do something which is more extensive. So this is a colon cancer, and you can see there is a metastasis on the segment 5, and this was the metastasis, and we resected the colon and we did a metastatectomy of the liver. So now there are liver first or colon first approach, which is the advances in GI HPB. That previously it was believed you take the colon or the rectum first, then you give chemotherapy, then you take the liver, which is called a metachronous operation. You may do a synchronous, you take the colon or rectum in the same go, at the same time you take out the liver disease, which is called a synchronous resection. And then came the liver first approach because people started believing the liver is the organ that actually kills these patients. So they would give chemotherapy downstage, go for the liver resection and the colon resection in the same go, or go for the liver resection only first, again stage it with chemotherapy, and then go for the primary, that is the mother or tumor. Coming to liver primaries, these are HCCs. Now, what is the advances in this? This surgery is basically previously it used to be a blind cutting. Nowadays, we have the volumetry, we have the angiography, we have the AI benefits. So we can actually map out the entire system. We know where is the right hepatic, middle hepatic, left hepatic vein, what are the tributaries, where are the overlaps, what are the chances of congestions of the liver, how much liver we can take, what is the anatomy of the portal veins, what is the anatomy of the hepatic arteries. And by this, whether there is a cross supply, and we can actually do a volumetry with or without the MHV and decide on how much liver we can safely cut out. So that 20, 30, 40% figure, thumb rule, is no more that important. You have a volumetry, you have ICG clearance, you know exactly how much liver you can cut out, how much liver you can leave behind to avoid a liver failure. But then, yes, obviously it depends. So what happens in liver failure is it's akin to or metaphorically similar to the small first size syndrome. You have the liver that you keep, there will be initial portal hypertension because the entire portal flow would be diverted towards that remnant liver. If there is a hyperdynamic circulation, if there are other metabolic diseases in the body, then the liver segment that you remains has to be larger. So you have to counterbalance between the necessity of the body and the capability of the liver to detoxify. If you can draw a balance of this, then the livers will not fail. So this is typically a left extended hepatectomy. This is the world's largest liver tumor, which had already shown the picture of the girl. This was almost 5.5 kgs and 45 centimeter in length. This is another HCC. Now, advances in the hepatocellular, I mean, the liver surgeries is that you do the hanging method, and then you would transect the liver after you have taken the extrahepatic portal vein hepatic artery. And once you transect, you can do a Glisonian approach. You can take it inside the liver also. So once you've started transecting, you would divide the the biliary radicals, the portal triads, you clip them, you will stitch them or tie them or whatever, you can even staple the larger ones till you go back. And then in the last step, you divide the hilum, preserving the bile ducts, most importantly, to the other liver. So that is the advances that have happened. We have the facility of ICG. There are AI computers which guides your technique, which guides your pathway is straight or it is getting curved. So many more advances and technologies that happened here. These are hemangiomas of the liver. This is what we were saying. This is the hilum. This is the liver has been transected. So these are different. Now coming to the recurrent pyogenic cholangitis, not much development. It is almost the same surgery. You can do more of endoscopic interventions. Then you can do a surgery. If one side of the liver is bad, you take it out. You do a bypass at the hilum. But all the stones has to come out, and you have to have an access loop for the future, or you have to have the main passage in place so that further therapies can be done when stones form later by endoscopic procedures. We know endoscopy has uh, big time come up in the subject of surgical gastroenterology. Now, when we're talking about bloodless surgeries, this is exactly how we can do a bloodless surgery. You see the main portal vein, the right hepatic artery, the bile duct, the left portal vein, the left portal vein branch chordet, the segmental branches, all have been taped. And now you can actually transect the liver in almost a bloodless plane by clamping that blood supply. In case you need to go below, you can come down further below to a larger vessel and clamp and actually get a complete bloodless plane. And that is the way you can do a as vascular surgery or like a liver, almost bloodless. Now, coming to few words about cystic diseases, this is classical hydatitis, the cartwheel appearance, the water lily sign. This is multilocularis. This is hydatid sand. This is again infected hydatid cyst. Where have we advanced? Previously used to be surgery, repair, uh, medicines. So those remain, but we have shifted to laparoscopy now. We would do a laparoscopic cystopericystectomy, or there is an exocyst, or it can be completely taken out. You do a open or a laparoscopic liver resection. So that is the advances, and you can do it robotic also. So robotic laparoscopy is just, I would say, an elder brother and a younger brother. But if you can do it laparoscopic, robotic has certain ease for the surgeon, for the comfort, but the surgery remains same. So this is infected cyst. These are polycystic liver disease. These are all our cases. So these are pictures that we have accumulated over the years. These are polycystic liver disease. This is a biliary cyst adenoma. And the advances that had happened is previously biliary cyst adenomas, we were confused about what exactly should be the extent of the surgery. The chances of recurrences were high, which were to be operated. Now, I was invited to give a lecture at the International Hepatopancreatic Biliary Association on the benign liver diseases, and they were discussed that nowadays laparoscopic surgery to enucleate it, to resect the liver, to decapitate it and completely fulgurate the base. These are different options which are very feasible and practically applied. Miscellaneous conditions like giant hemangiomas, then infections. Now, another advancement that we do in our practice is for the large liver abscesses. When you thick abscess, you can't really drain it by percutaneous methods. We don't do just a laparoscopy. We do a laparoscopic port and then we puncture the liver directly, go inside the liver. So we call it a hepatoscopic debridement. And then we aspirate the pus. We put in 2, 3 ports inside the liver cavity and we do the operation from within the liver, not just within the abdominal cavity. And then we would put in drains and come out. So that keeps the rest of the abdomen from without any spillage or without even touching the rest of the abdomen. So these are PLAs. I'll skip these slides. So this was the largest hepatic artery aneurysm ever recorded in the world. We operated this in 2008. Now, not much advances in these surgeries. It remains same. You have to find out the inflow, the outflow. Then you control them. You open up. You take the thrombosis out. You excise it. You find the GDA branch. You stitch it up. So I'll skip this. But this is something where a lot of things had happened over the last many years. We all know that the difficult gallbladders where the callots was frozen was always an open surgery. There were more high chances of conversions. Now we started, reported, and was published long back that in Meniere's syndromes, we were doing laparoscopic procedure. We were increasing the number of subtotal cholecystectomies, keeping a stump of the GB, which we would use to stitch a flap on the bile duct, which was called the flap choledocoplasty. So we used to take out the gallbladder, do not allow the CBD to be narrowed by using the GB neck flaps to close on it so that it becomes enlarged and widened. We do not have a stricture in the long-term one follow-up, yet all the stones and the pathological organs have been removed. So initially we were criticized many years back. Now everybody accepts this. This is a known procedure of subtotal cholecystectomy or a near total cholecystectomy. It's a gallbladders like this, which you can't make out. What we do is you somehow dissect, you can't see the CBD. Yes, ICG can help, but sometimes in ICG you can only see the structures. But once you switch off the ICG or keep it on and you try to dissect, you can still injure the CBD. So the best way is you do an anterior cholecystotomy, take all the stones out, see the duct from inside instead of seeing it from outside, which is not visible. Then you stitch it up and you cut around the level of the duct and use the flaps to close onto the pile duct. First, we would always try to take the cystic artery. This is same thing what we are doing here. We have taken the cystic artery, then we have clipped it. In some cases, you can do a fundus first, but in fundus first, also the bile duct gets tinted up. You can actually land up with a bile duct injury. So the safest way amongst all the different methods described, where you can't have a critical view of safety of Strasbourg, you cut the GB open anteriorly, go down as far below as the neck. From the neck, you can see from inside of the GB where the CBD lies, and then you can plan your surgery. And this is how we then open up the GB, taken stones out, and this is exactly what happens is you keep a small cuff of the GB. This bile duct is usually narrowed. You widen it by the GB flaps. So this is a major advancement, and walled across this surgery is being done routinely in more and more places. You stitch up in a way you not only make a flap, but you also obliterate the chances of a stump syndrome. Even as bad gallbladders like this, which were previously either went to a cholecystostomy, a percutaneous cholecystostomy, open cholecystostomy, or nothing but a debridement or a drainage, or maybe at best an open surgery, are also routinely, even with such big gangrenes and perforations, are being done laparoscopic. In biliary surgeries, frankly speaking, not much changes has happened. That biliary strictures, one of my favorite surgeries, used to be the same hanging method and parachute method of hepaticojejunostomy. It's not much advancement in that because those remain same. The only certain differences that happened is more knowledge, more trials, more evidence based to know exactly what we're doing here, right or wrong, where to stand, where not to stand, when to do a PTPT. These are the changes that have happened. Coming to last few slides of pancreatitis, I'll not go into acute pancreatitis because there are too much to say. But this pancreatic pseudocyst. So the surgeries that have evolved is more shifting to endoscopic procedures, shifting to robotic procedures, shifting to laparoscopic procedures. And very few are actually done in open surgery. The cystogastrostomy remains same, the necrosectomy procedures remain same. And if this is a world of pancreatic necrosis, the definitions have changed. Whether you get a necrotic tissue, you called it pancreatic necrosis. You get no necrotic tissue, you called it acute fluid collection or a pseudocyst. So they are no more interchangeably used. So those definitions have evolved over the life, and that has actually made easier for the surgeon to define the treatment, and also has importance in terms of medical legal implications. These are chronic pancreatitis with stones. Then there is serous cystadenoma, which are cystic neoplasms of the pancreas. Then there are mucinous cystadenomas, the IPMN, the neuroendocrine tumors. So this is an insulinoma. This is a VIPoma being taken out by us. This is a gastrinoma. Again, not other than investigation advancement, where you can more likely to pick up the diagnosis and localize the tumor by a Doppler PET. I don't think surgeries have evolved much. It is same more or less, except for that you do it open or laparoscopic or robotic. You may use endo ultrasound to intraoperative ultrasound to locate the tumor better. And apart from that, not much changes over the last 20, 25 years. Ablations have come in, RFA ablations have come in. That is something which still is not, I would say, a replacement of surgery, as not there adequate evidence and long-term follow-up. Coming to the final slides and my most favorite surgery, a lot of changes had happened in Weeples. Different types of Weeples reconstructions have formed: PJ, HJ, GJ. Now there is a long staple GJ, a vertical GJ, a short staple GJ, a short GJ. So a lot of changes had happened in Whipple surgery, but still by and large, it is either a Travers-Longmire, that is duodenum preserving or pylorus preserving pancreatoduodenectomy, or a classic Koch Whipples where you take the part of the duodenum and the antropyloric region of the stomach. What has evolved is the knowledge that you have to do a total mesopancreatic excision. So there should be no tissues between portal vein, the uncinate, the SMA, and the stomach, the pancreas, the portal vein, the IVC, the left renal vein, the kidney, the hilum of the liver, the caudate lobe, everything should be bare. So you do adequate oncological clearance, because doing a surgery is just part of it. Pictures don't speak of results. Your results have to be good. You shouldn't be having leaks. The patient should be able to eat without complications. The patient should stay for the minimum time in hospital, so ALOS goes down. And then once the patients are discharged, you have to have a follow-up of long term, say 1 year, 5 year, 3 year, 5 year, 10 year, like that. And then only you'll know that, okay, things we have done is right. And then you have to actually analyze the data to know what are the variables and how are the variables affecting the results. So this is my most favorite surgery. I recently gave an oration for the government of 656 Weeples, multiple vascular resections in them. And fortunately, one of the best results in the world. We have only three patients who have died, 653 consecutive. I mean, not consecutive, there have been deaths in between, but 353 are alive and quite long term. Last but not the least, multivessel dissections have come up. So previously, a tumor like this would be left and the patients would have died. But now we do not believe in that. This is a surgery we had done 19 years back. Since then, the opportunities have been less, but wherever it had been, we had grabbed onto them and we have done those multivessel surgeries, especially in cases of benign disease, also in cases of cancer, provided the patient has a good GC score and the patients are young, expected to survive. So we would take that risk. And this is a case where you can see a tumor of the adrenal which is ruptured, involving the other structures. So we had taken out the spleen, the distal pancreas, a sleeve of the stomach, a segment of the colon, the left kidney, all the tissues along with it, the left adrenal gland, and the entire specimen had come out. So what we strongly believe, these advances are possible. This is not my picture, a picture by a very famous photographer which got an international award. And this picture reminds us that it's an interdepartmental liaison in face of catastrophe. And that is exactly, I've spoken about what surgeries we have done, what are the advances in GI, HPB and surgery. But what we have not spoken about are all the so many shadow players behind the screens. We see actors, lead actors on a movie, but we don't see the entire team. So it is an entire team effort, for starting from the anesthetists, the critical care specialists, the pathologists, the radiologists, the medicine, internal medicine guys. So everybody pitches in to actually lead to a success of individual case. So interdepartmental liaison in face of a catastrophe is more important. And one smile is worth a million obstacles. That's my true belief. And this is a picture again from during the Kargil War. So this gentleman, like I say, like I practice, integrity doesn't come in patches. This gentleman, even on a Kargil war day with heavy bomb shelling and stuff, is selling flowers in the beautiful valley of Kashmir. So that reminds us, that should remind all doctors that this is what we are meant to do. We are meant to serve, we are meant to bring smiles, and we are meant to try to save patients, as many as possible. And I truly believe, I keep learning, I keep reading till 4 a.m. in the morning every day. So knowledge is like this river, and my quest is like the boat ahead, moving ahead in search of its end. And this had always been my last slide. I have got multiple medals at multiple levels, multiple national, international awards. But I always cherish this because this was the All India topper medal, which was given to me in 2006 from the ministers of the government of India. So as an Indian, it was a proud moment for me. I was also the first Bengali, and I was the first from the Eastern India, because there was a train that most of the medals used to go to the other parts of India. I was the first to start the train in 2006. So I always show this as my last, because difficult memories makes you feel that you should remain uncomfortable and dissatisfied so that you don't fail in life. Thank you. Over to Saurav.
Thank you for the wonderful presentation and congratulations on all the achievement. Very well said that doctors are here for bringing smile and saving patients. Just one question to you. You're sleeping at 4 in the morning, so how many hours do you sleep?
Me, I used to sleep 2 hours a day. Now I try to sleep at least 4 to 5.
Is that healthy?
I used to be into a lot of things. I was very heavy gymming and all sorts of athletics and sports and martial arts and rock climbing and God knows what. So
Okay.
I was pretty fit. I could handle.
You're technically somebody which doctors do not encourage. Gymming is not something which doctors do encourage, and sleeping less than 6 hours is not what you encourage. But I think it's a very, very important message from your end, and I think you're a role model for a lot of people. Over to Dr. Chong and everyone over here. Wonderful session, and let's do the question answers.
Thank you, Dr. Sen. Your presentation was most enlightening. I'm a physician, I'm not a surgeon, but nevertheless, have a couple of questions for you. What do
Yes,
you
sir.
have?
Sure.
Do you all do peritonectomy, like high pecs and those sort of procedures as well?
No, I don't do hypec or peritonectomy. I used to do long back, but nowadays the younger oncosurgeons have taken up. Now the hospital that I work with doesn't have an hypec, so I am not directly into it. But there was a time when we used to.
Okay. I
But these
also,
are being done at 2, 3 centers.
okay, thank you. I also have another question. Being involved in some of the care of my patients with these pancreatic lesions that we discovered on imaging, we always are very worried about the final histopathology. That means after the surgery comes out and everything's benign. I mean, it's like, what are your thoughts on this part of the
Yeah,
difficulties of pancreatic surgery?
yes. See, I think the most important challenge in today's world are the medical legal aspects that are increasing day by day.
Yeah.
So from that point of view, once we have a biopsy proof of which would go forward towards surgery, makes it life easier. Because unless you have a biopsy, you have taken a decision for a major surgery and later it comes out to be benign. We may
Yes.
be in relief, the patient may be in relief, but then again, there is a question of a medical legal angle. Why take the patient for a surgery? So
Mm.
yes, that is a controversial place, because in periampullary lesions or a duodenal mass, you can still have a biopsy. But in head pancreas or the cholangiosis, the biopsies are mostly negative. Uh, Open biopsy is contraindicated. It is relatively unsafe. You can do an endo ultrasound guided. We routinely do, but most of the times it comes out to be negative. You do it once, twice, it comes out to be negative, because we know that in pancreatic cancers, these are typically very desmoplastic reactions with very scarce cells. So it's very difficult to get a yield on biopsy. So
Mm.
these are mostly based on your clinical findings, your what is the grade of obstructive jaundice, the weight loss, anorexia, the pain, the
Yeah.
size, the location of the mass, what is the irregularity of the pancreatic duct. You're pretty sure this is a cancer. The tumor markers are high, CA 99, CA is high. You would counsel the patient and go for surgery. Even I have had faced patient recently. One patient had just a 2 centimeter periampullary lesion. Biopsy was taken, was negative. We went
Mm.
ahead with the vehicles, and then patient had a heart failure in the post-op and a cascade of problems. So obviously the relatives went into a 180-degree switch and said, why operate this patient when you're not sure this was cancer?
Yeah.
Luckily, the biopsy histopathology came out to be cancer. Yes, we know these are sticky grounds, but still, I think by and large, clinically, radiologically, and plus minus histopathologically, if you have a support, you can go in for the surgery. Even if you don't have a histopathology support, have you tried to get it? Is it possible? then you can go for a surgery, irrespective of it is positive or negative. But in case you can't go for a biopsy, then you have to counsel, get the consent signed, just treat it like legal documents and go ahead with the surgery and the risks involved.
Yeah. Thank you for that. That was very enlightening, and it is an area of difficulty that you've acknowledged earlier on in your talk. So, you used the word medical legal, I remember. Thank you so much. Those are my questions for now. Any questions from the floor?
This was a side of what doctors would prefer. What about the patients? Like, patients have a lot of difficulty in choosing whether they need to go for a surgery, whether it is just is it a cancer? It can be treated. Is it a cyst? It's just a tumor? That basically that round of discussions, having a second opinion. How about
Right.
patients deciding that part?
See, what we do in the difficult cases. Now, I have been HOD and director of almost all the top corporate hospitals since my age of 31. So I'm 50 almost now. And so that's the reason people know me here and they come directly to my name. So whatever I suggest, they would accept. But then I get a lot of patients from the US, Canada, the Latin America, the Europe, Australia. May not be in high volume since I don't have a professional tourism setup, but from rest of India. And some of them ask a lot of questions, like you said. And them I suggest that after every discussion, I give a lot of time. I give maybe half an hour, 1 hour per patient while discussing all these things. And then whoever gets convinced, we get all the consents and the right everything documented in writing. Still, if somebody has a doubt or a dispute, we always tell them, please go and consult any doctor or center online or offline of your choice and get a second or a third opinion. So after that, if you're convinced that what we have told you is the right direction and you want to choose us, please come back to us. And that has always worked for us. People would come back.
Yeah.
Rather than them seeking a second opinion, it is better that you tell them you go for a second and third opinion to clear your doubts.
Thank you, Dr. Sen. You've really touched on a very difficult area as we spoke of. Yeah. And any questions from the floor? Any other questions?
We have another question. It says, what are the common signs of somebody having a liver, pancreas, or gallbladder problem? And what test needs to be done to detect these cancer in the early stage?
Okay. I think yesterday only I have a video posted. I mean, anybody can follow me on Google, on LinkedIn, on Facebook, on YouTube channels, and all these questions have been answered multiple times on videos and statements. But I'll just to sum it up. Whenever you're having any feature which is persisting, I'll come to the features later, which any persisting feature beyond 2 weeks, which you didn't have before. You have tried basic medicines, it is not getting relieved. Your age is above 40, or you may be younger, but you have history of cancers in the family. Please go ahead and see a doctor. That is the first most wise step to do. Now, coming to the symptoms, it may be early jaundice, it may be early pain, it may be completely symptomless. Because, see, early stages of cancer are very evasive to diagnosis. They do not usually cause symptoms. And that is exactly the reason when it is symptomatic, the tumors is usually more advanced than the early stage. But you still have a subtle sense of weight loss, a subtle sense of anorexia that you lost your appetite, you may be having slightly yellowish tinge of the eyes or yellowish urine. But these are also overlapping symptoms. You may be having gaseous bloating, and a lot of patients of gallbladder cancers come only with dyspepsia. So problems of hepatobiliary pancreatic cancers is that you cannot diagnose it early unless you're very, very, very careful and conscious about your health. That you find the slightest symptom which is not normal to you, you go and consult a doctor and get yourself investigated. But just to add on, one factor what we get is sugar patients, new onset beyond 40, or the known diabetic, suddenly there is fluctuation of the sugar levels. A lot of doctors miss this. Please get a CT scan done because you may be harboring an early pancreatic cancer.
Yep. Thank you, Dr. Sen. Very, very, very astute, very, very clever pointers for the layman to note.
And what is the correlation with the diet over a period of GI cancer, any of the GI cancer? Is there any relevance of a diet over a period of time since childhood?
Yes, I think we all know that spicy diet adds up to reflux. Reflux can add up to Barrett's esophagus, and some of them can become esophageal cancers. Smoking addiction, alcohol can give rise to cancers of the pancreas, bladder, lungs, esophagus. So those we are aware. Regarding diet, we know how the Japanese have advanced in cancer surgery. You see, it is because the debacles in Japanese had opened the opportunities better for them. And I would not say the Japanese have become so good surgeons, they are so lucky. I would say they are unfortunate that they have more cancers, and that's the reason they had to become better surgeons. So if you look at the diet of the Japanese, the smoked fish, the all these things, those have added up to a lot of cancers. Similarly, your diet has to be a balance of all the vital elements. You must have minerals and fruits adequately, and exercise and sleep and all those stuff, which is adequate for you. But Percy, that as you don't really have a diet correlation which would prevent a cancer if it is to happen in your life. Because non-smokers land up with cancers we have seen, and smokers not having any problem. But yes, smoked fish and nitrosamines in the diet and junk foods, there are more chances. We all know about that. But probably one thing which has been to my mind that comes, the only thing that has proved to prevent cancer on randomized trials is caffeine. If you take a lot of caffeine or bitter things, then it keeps the liver healthy and chances of liver cancers are diminished. That is a proved fact. And there are certain other foods like that, which prevents a certain cancer, maybe. But the problem is, it is always a trade off. Nothing comes for free in this world. You trade off, you take caffeine, you are happy you don't have liver cancer, but you may develop gastritis, you may develop gastroesophageal reflux disease, which in turn leads to esophageal cancer. So take everything in moderation. Nothing more, nothing less is going to prevent a cancer if you have it in your gene and if God really wants you to go there.
Thank you, Dr. Sen.
Dr. Sen, just to add over here, we have recently seen in India a cricketer celebrity has made a claim that his wife, on the basis of diet, has reversed the cancer just based on the diet.
Yeah,
So
right. I think if I'm a celebrity, you give me a good mileage and maybe a backdoor good contract, I'll say that my hair fall saved me from death. Doesn't matter.
okay,
I'm
great.
Dr. Kiran. I just want to quote that there were 5S for gastric cancer:
Yes, that's right.
spirit, sleep, I think, and spices.
Mm.
There are two more: spirit, spices, sleep.
Smoked
What else?
fish.
Smoke, yes. One more S. हो गया. We were taught in MBBS. Thank you.
Great. Would you like to make any comments? Monica?
It was a great presentation. I also want to say that it was serendipity that your last slide actually was a perfect cap to the conversation that we had started at the beginning of your presentation, talking about finding your path, taking care of patients, finding the peace in the calm to make sure that we can provide that care. It was a fantastic last slide. And congratulations to your accolades. Continue to find the accolades in all the people that you help, whether it be your
Thank
patients
you.
and whether it be your colleagues to make them better in terms of how they treat their patients. You have done phenomenal work, and thank you so much for joining us today.
Thank you. All I can say is I just end with this words that we would always touch somebody else's life. It is in our wisdom to touch it in a way so that we don't leave a scar, but a healthy memory.
Dr. Heidi, would you like to say something?
Thank you.
Okay.
Surat, if there's no more questions, maybe I'd just like to end the session and thank Dr. Sen for his wonderful
Thank you.
presentation. Dr. Sen, it was a very multifaceted presentation, technical at times, but yet we got the grasp of what you're trying to tell us. And even then, you also addressed some of the other issues from our laymen watching us, as also from me, for example, my physician point of view of medical, legal, and so on. And quite philosophical, some of your things that you talked about that have come from years and of accumulated wisdom. We thank you very much for this talk, and we look forward to
Thank you.
hearing from you again.
Thank you. Thank you for having me.
Thank you.
Thank you. So do I leave with your permission?
Just know we would like to end this session. I think we would invite you for follow-up sessions. Very important topic.
Sure.
And thank you everyone for joining in.
Thank you.
Thank you.
Thank you. Thank you.